Welcome to the Connecticut Orthopedics Evaluation and Management of the Lumbar Spine Continuing Education course, presented by Mike McKenna, Ed Strosnick, and Chris Miller. This is a hybrid course. This will be the online portion, and we'll meet for 2 hours in person to go over some last pieces of the lecture, as well as a lab component. Enjoy. So we're going to start here by reviewing some of the epidemiology surrounding low back pain. Low back pain has a 50 to 80% lifetime prevalence, which means the vast majority of people are going to experience back pain at some point in their life. Point prevalence ranges between 1 and 58%, which is obviously a large range. A lot of this depends upon how we're defining low back pain in a given study, as well as the population that we're looking at. The one-year incidence of a first ever episode of low back pain ranges between 6.3 and 15.4%. So between 6 and 15% of people will experience low back pain for the first time ever in a given year. The one-year recurrence rate is 24 to 80%. Now you can see on the high end there, 80%, that's a pretty high rate of recurrence of low back pain. So many people that experience it at some point in their lives are likely to experience it again. The incidence is highest in the third decade of life, with the prevalence increasing up until the 60s, at which point it flattens off. So starting around the third decade, is when we see the highest incidence of low back pain. The prevalence, meaning the amount of people who have low back pain, increases up until our 60s, at which point it flattens off. And the one-year remission rate is really high, between 54 and 90%. So anywhere from half to 90% of people who experience low back pain will get better within 1 year. Which is positive, but like we said, that recurrence rate is pretty high too. So that means years down the road, it is reasonably likely that they may experience another incident of low back pain, having had it before. Given how common low back pain is in the general population, it's not surprising that it causes a pretty substantial burden on society. It's actually pretty highly correlated with mortality. It's a leading cause of global disability worldwide. It's the most expensive medical condition in the United States, costing about $134.5 billion on healthcare, another $7.4 billion in lost productivity. Now, most of this is coming from recurrences of low back pain, so not initial episodes. Like we said in the previous slide, low back pain is very common, and the vast majority of people who experience it are going to have a recurrence at some point in their lives. It trails only headaches as a pain-based cause for lost productive time in the United States. So it's having a pretty big impact on productivity nationally, as well as placing a substantial burden on the healthcare system. Given how substantial of a problem back pain presents, the research has been able to identify a series of risk factors for people who are more likely to experience low back pain. Some of those include job dissatisfaction, stress, anxiety, depression, low educational status, gender, smoking, obesity, low physical activity levels, and exposure to a more biomedical interpretation of low back pain. Now, this makes sense. If we look at these risk factors, not all of them are biomechanical risk factors. It doesn't say a job that requires standing, it says job dissatisfaction was the risk factor. So obviously, biomechanics are insufficient by themselves to explain most causes of low back pain. There have been some studies of Latino American immigrants in the United States and of Australian Aboriginals that found that exposure to a more biomedical interpretation of low back pain increased disability by shifting previous beliefs that back pain is benign and a normal part of everyday life towards back pain being a medical condition that requires attention and treatment. This will inform how we do treat those who seek treatment for low back pain, that we want to avoid these highly biomedical explanations for why their back hurts. In addition to identifying risk factors for low back pain, the literature has also identified protective factors, moderate levels of leisure time physical activity, so being able to exercise outside of work, work-related physical activity or occupational-related physical activity is not a substitute for leisure time physical activity. It actually appears that occupational physical activity does not confer the same protective effects that leisure time physical activity does. Walking or cycling to work, which could fit under the category of leisure time physical activity. High self-efficacy. This was measured by a scale called the IC, and basically it asks people to rate several statements as either strongly, moderately, or slightly agree or disagree. And it has statements such as, my well-being depends to a great extent on the behavior of other people. It is sheer coincidence when somebody else ever considers my wishes, things like that, to evaluate how high somebody's self-efficacy is. So higher self-efficacy is related to a decreased likelihood of experiencing low back pain. High social support at work and higher hand grip and trunk strength are also protective factors against experiencing low back pain. Next, we're going to go through a series of slides focused on a series of papers in the Journal of The Lancet focused on low back pain. You have a quote here from that series that I thought was pretty important. The surge in global low-value care for low back pain that includes presentations to emergency departments, liberal use of diagnostic imaging, opioids, spinal injections, and surgery has also led to skyrocketing medical and human costs. Now, the reason I think this is important is you'll notice what's not in there are some of the things that we have to offer. We can help contribute to improving the quality of care for patients experiencing low back pain. This is going to be exercise, manual therapy, things that we offer that can help avoid presentations to emergency departments and opioids and injections, surgery, imaging, all of that stuff. The problem is if we don't do a good job treating low back pain, we're not following current literature and offering the highest quality care, it's not likely that we're going to be able to decrease the incidence of these other types of treatments. And so that's where I think some of this stuff can help. We'll kind of go over some of the literature, what constitutes high quality care in our setting. These are a series of recommendations that came out from that Lancet Low Back Pain series. Some of them more pertinent to us as rehabilitation providers than others, so there's a couple that I'd like to highlight. One, patients should be taught to self-manage low back pain and seek care only when really needed. We need to be delivering a message to our patients that their bodies are resilient, that this is not a scary thing. It may be frustrating, it can be seriously impacting their life, but it's not a medically scary condition. And that the best care is going to involve self-management. We should be updating home exercise programs. We should be delivering a home exercise program right off the bat on the first visit and updating that routinely throughout the process. Another one where I think we can help in a big way is widespread and inaccurate beliefs about low back pain in the population and among health professionals should be challenged, and a focus on reducing the impact of low back pain on people's lives rather than seeking medical treatment for a cure. Now, patients come in with a lot of preconceived ideas about what back pain is and what they need. I can't tell you the number of times I have somebody comes in that's frustrated because they couldn't get an MRI, and because how else could you possibly know how to treat it? We don't know what's going on in there. And having these conversations with patients about why that might not be the best idea and how that's not going to necessarily change the way that we're going to approach treatment is important. The other part of that, though, is that those beliefs are usually coming from a healthcare provider. They've heard that from someone, somewhere. They've been led to believe that they need imaging in order to properly manage their condition. And so we need to be comfortable having these conversations with each other, where if we are kind of delivering that more biomedical explanation, biomechanical explanation of somebody's low back pain, that's going to lead them to believe that they need to see an image, they need to see if the jellies come out of the donut to be able to tell how we're going to treat this thing. We need to be able to have these conversations with each other as well. And it can be done gently. It doesn't have to be super confrontational, but I think we've all let slip sometimes with, we just sort of dove on the simpler explanation than the more complicated thing that, back pain's not that simple. It's not one thing 90% of the time. It's 100 different things that all came together all at once that led you here into having some pain. So I think that's an important one, is that we need to be comfortable and get comfortable having these conversations with each other so that it doesn't propagate further to the patients, because that's where they're learning this. They're hearing it from us. Some of it is on social media, that kind of thing, but at least we can control the clinicians that we interact with on a regular basis. This image comes from the same series in the Lancet, and I think just drives home the point that I was discussing on the previous slide, that back pain is not quite as simple as one thing, at least not usually. Now, the one thing that we tend to focus on from this chart is the nociceptive input. So, the disc, the facet, motic changes, whatever the case might be. But you can see all of these things, the biophysical factors, comorbidities, social factors, psychological factors, genetic factors, all contribute ultimately to the pain experience and the disability that the patient is experiencing. So I think it's important to keep in mind all of these things, and this is a benefit to us. If there were only one thing that were causing somebody's low back pain and it was a purely biomechanical or biomedical thing, we would have a limited ability to have an impact on that. But these are all levers that we can pull to help improve somebody's condition. We can certainly help with psychological factors with things like graded exposure, pain neuroscience education. We can help with comorbidities by getting them moving, getting them active, and affecting, whether it's weight or diabetes, improving sugars, all that kind of stuff. So there's a lot of levers that we can pull to help somebody improve. We're not stuck to just trying to improve biomechanical factors, because when that doesn't work, or if that doesn't work by itself, we would be in trouble. But we have all these other things we can have an impact on, and I think that gives us a lot more ways to help our patients. The Lancet series goes on to discuss causes of, or potential causes of, low back pain, such as the disc, facet joint, vertebral end plate, and other specific causes. Now, what they're looking at here and what they discussed was, are there clinical tests to determine if this specific tissue is causing the patient's low back pain? In a lot of cases, in fact, in most cases, the answer is no. So with the disc, there's no specific reference standard. With the facet joint, clinical identification of facet-mediated pain is not possible. With the vertebral end plate, again, clinical identification is not possible. Where we need to be focusing our time and attention and making sure that we're not missing things is this last section here, the vertebral fractures, inflammatory disorders, malignancy, infections, and intra-abdominal causes. These are causes that require a specific treatment, and oftentimes it's not a treatment that we offer. They need to be referred out. They need some type of medical treatment, whether it's a medication, a surgery, whatever the case might be. We need to be on the lookout for these to make sure that we're not treating these patients as if it's a traditional mechanical cause of low back pain, and all along they had an axial spondylarthropathy or some kind of malignancy that needed to be managed differently. Interestingly here, there's not a lot of clinical tests to test for many of these causes. Most of what we're going to do to rule out these causes of low back pain is actually going to be as part of our subjectives. We need to be asking the questions that will elucidate and clarify if their back pain might be coming from one of these causes. This is going to be things like night pain, constitutional symptoms, weight loss, those types of things. So we need to be making sure that we're asking those questions during our subjective. Here we have some more findings from the Lancet Low Back series on the topic of causes of low back pain. Again, they say clinical tests are unable to diagnose the course of most low back pain. Many imaging findings are common in individuals without pain. So we get that patient that comes in with an MRI or they had an X-ray and they've been told they have stenosis or arthritis or degenerative disc disease or whatever the case might be. These findings are pretty common in patients without low back pain. So in and of itself, that does not explain why they're experiencing pain. There are some findings that demonstrate reasonably strong association with low back pain in the literature. These include modic type 1 changes, disc bulges, disc extrusions, and spondylosis. There is, however, no evidence that imaging improves outcomes. Because again, we're not treating modic type 1 changes. We're not treating a disc bulge or an extrusion or spondylosis. We're treating the patient in front of us. And our evaluation is going to determine what their treatment is going to look like, not the specific pathoanatomic diagnosis that they have. And this is likely why, again, imaging does not improve outcomes. The guidelines, in fact, consistently recommend against using imaging because, again, we talked about earlier, that these pathoanatomic, biomechanical, biomedical explanations for low back pain actually worsen outcomes over time. Instead of this idea that back pain is just a symptom, it is something normal that is a part of life and most people are going to experience at some point in time. So why does it all matter? Why go over all this stuff from the Lancet Low Back series? Why do these beliefs need to be confronted? All of that kind of stuff. This line comes from a paper from Guillaume et al. While helpful beliefs and guidelines, consistent decisions were generally identified. Unhelpful beliefs about back protection and the special nature of low back pain were frequently present among physiotherapists. These unhelpful beliefs were associated with less optimal clinical decisions. Educational approaches should challenge unhelpful beliefs and empower physiotherapists to provide explanations and management that increase patients' confidence in the back. Future research should investigate the effect of educational strategies on implementation of best practice for low back pain management. So basically, physical therapists, or in this case physiotherapists, who had unhelpful beliefs surrounding low back pain, that it was basically a serious medical condition or relied on pathoanatomic explanations for pain. We're more likely to rely on rest or more passive strategies for back pain recovery. These are the less optimal clinical decisions that they're discussing in that paragraph there. And this is why I said earlier we need to be comfortable having these conversations with each other. I'm sure we all have some beliefs that are not grounded in the literature or are particularly not helpful to our patients. Because again, our patients are getting these beliefs about low back pain from us, from the healthcare providers. And we can be the ones that put a stop to it. It's not always easy. Sometimes it takes a lot of visits. Sometimes patients are resistant to learning new things, but we need to be willing to have the conversations with patients as well. But if we are consistently feeding these unhelpful beliefs to patients, low back pain broadly, societally, is unlikely to improve. We need to be instilling confidence in our patients, not that the back is special and needs protection. The back is a group of joints and muscles and ligaments and tendons, the same as any other joint. For whatever reason, we often treat it as different, that if you feel anything there, it means you're doing it wrong, or we need to avoid that movement, or we need to change it, or something like that. And that's just not true. If we feel like put a patient doing a long arc quad and they're like, oh, I feel it in my knee or my thigh or something, we don't generally tell them to stop. We say, yeah, that's exactly where you should feel it. We should be taking a similar approach with low back pain. And again, it's okay to identify, like, okay, is this pain versus is this muscles working, a little sore, a little achy, that kind of thing. But we shouldn't be just avoiding any type of sensation in the low back. And it doesn't matter whether we're talking about doing an exercise like a deadlift or a bridge. It's okay to let those paraspinal muscles work. They're there for a reason. And so we need to kind of confront the unhelpful beliefs that are pretty pervasive among physical therapists, that the low back is special and needs protecting. The message needs to be about resilience. That's what's going to help our patients the most. Moving on from the Lancet Low Back Pain series, now we're going to discuss prognosis a little bit. The good news with low back pain is that it usually improves rapidly. Significant improvements occur within a month, and generally improvement continues until about 3 months after onset. This is similar to what we discussed in earlier slides, that most people experience remission inside of 1 year. And we would expect the bulk of the improvement to occur early, and it sort of tapers off with time. The problem, again, that we discussed earlier is that recurrences of low back pain are pretty common. Most people are going to experience a recurrence within about 12 months. So despite the positive early prognosis that most people will experience remission within a year, they will also likely experience a recurrence within that same year. So for most people, a low level of disability often persists. They have some on-again, off-again low back pain. I think we've all treated this type of patient. We've all heard this story from a patient, that, they have a ongoing sort of waxing and waning back issue. Sometimes they'll say, oh, I have a bad back. That may be one of those opportunities for us to educate patients a little bit and try to instill a message of resilience, because certainly describing your back as being bad is not a belief that your spine is resilient and that you're going to recover. Which brings me to the last bullet point there, that the patient expectation of recovery is going to play a large role in how people do. Those who expect to recover well, those who expect to get better, who view it as, this is just some pain, I just need some strategies to help manage this thing, and then I'm going to move on with my life. Those are the people that are generally going to do the best. The people that come in, feeling like this is a serious, scary medical condition, they seem very stressed, very anxious about it. They don't feel like they have a lot of support. They have a lot of the risk factors that we discussed in earlier slides. These are the people who are likely going to have a little bit more difficulty. Now, again, we can have impact on those things. We can, share a message of resilience with these patients, and I think that's important, that we're kind of instilling in them that, again, we don't want to be dismissive of their complaints. It's not that this is not serious to them. It is not serious medically. It is not dangerous. It hurts a lot, doesn't make it any less frustrating, doesn't make it feel any better, but it's not a scary thing. And it is actually very common. Like we said, the vast majority of people will experience low back pain at some point in their life. So trying to help improve their expectations of recovery can also help us deliver a better outcome. So what puts somebody at risk for transitioning from acute low back pain to chronic low back pain? There's a study done by Stevens et al. That examined this question. And one of the first things that they found was that the start back classification tool, that's the SBT stratification tool, that helps stratify people into low, medium, or high risk from transition to acute to chronic low back pain, was a pretty effective way of determining how at risk they were. People that fell into the low risk category were 19% likely to transition to chronic low back pain. 33% for the medium risk, and the high risk group was about 50-50, 49% of those individuals transitioned from acute to chronic low back pain. The start back tool is a 0 to 9 scoring scale with a 0 to 5 psychological subscale, so it does examine the psychological side of things as well. And can be a useful way to determine and help guide treatment decisions. Does this person need a little bit more care? We need to have them in a little bit more often because they fall into the high risk group. We can help deliver that message of, the resilience of the spine, and that this is not a medically serious condition. Most people do improve with time. It's not because of just the stenosis. There are multiple other factors that may be playing a role. Versus somebody in the low risk category, maybe we need to get them on a home program, see them once a week or every other week, just to update that, and they can manage the rest of the way on their own. So the SBT can be a good tool to help identify those patients. Body mass index was another risk factor. Psychological comorbidities, in other words, anxiety, depression diagnoses, smoking status, Medicaid insurance, and then exposure to guideline non-concordant care. The more often somebody was exposed to guideline non-concordant care, the more likely they are to transition from acute to chronic low back pain. In other words, the less likely they are to get better. The three main areas where people were exposed to guideline non-concordant care were early diagnostic imaging, early subspecialty referral, and pharmacologic therapies, primarily focused on opioids. And with each exposure, the person became subsequently more likely to transition to chronic low back pain. In other words, less likely to get better. So if they had none, 0 to 3 exposures basically go from 27% to 53% from bottom to top. So again, almost doubles their risk of transitioning to chronic low back pain. The more often somebody is exposed to guideline non-concordant care. So again, it just underlines the importance of us being able to have these conversations, identify where these problems are occurring. It's going to give our patients the highest likelihood of getting better and not being stuck with chronic low back pain. So all this talk about guideline-based care, I just want to touch on briefly and a little bit more specifically, what does that look like? And so the first thing is reassurance. There's a very, very low likelihood of serious underlying pathology. And this is what I mean when I continue to say this is not necessarily a medically serious condition. It can be very serious. It can interfere with your life in a very major way. But there is a very low likelihood of serious underlying pathology. And it's important to get that message across to patients without seeming dismissive. Advice early on to continue activity as tolerated. Again, we don't want to be recommending bed rest or, try not to do X, Y, Z, try to avoid this, try to avoid that. As long as it's tolerable, generally the best course of action is going to be to try to continue to maintain your activity level as much as possible. Thrust and non-thrust manipulation, which we're going to go over in a little bit more detail going forward. The in-person part is going to be focused almost exclusively on thrust manipulation. We'll talk a little bit about non-thrust manipulation here. Exercise, good news is a lot of options there as far as exercise goes. A lot of different ways that we can approach that. There's not a ton of right and wrong. And then some pain neuroscience education. So what is pain? What is pain not is also really important. Pain is not necessarily indicative of serious tissue damage all the time. And that's an important message to get across to patients as well. So these are all things that kind of fit in under that umbrella of guideline-based care that are really our purview. And again, I'm going to keep beating this drum that reassurance is an important one, because I do think a lot of people come thinking that low back pain is a very serious medical condition that requires a lot of treatment, and that they need to find, they need a cure for it. And in order to get that, they need imaging and they need to know exactly what's going on. And so some gentle kind of redirecting and patient education goes a long way here. So we have some interesting evidence maps that came with the 2021 JOSPT clinical practice guidelines for low back pain. This is for acute low back pain. The next slide is for chronic low back pain. We'll go over both. But basically, it categorizes varying interventions into should use, may use, can use, or knowledge gaps. With should use, where they have a good amount of level 1 or level 2 RCTs. May use is a single level 1 RCT or small sample level 2 RCTs for short-term follow-ups. Can use just a single level 2 RCT. And then knowledge gaps, there's really no good randomized control trials demonstrating efficacy for those interventions. And so the bulk of our treatment should be comprised of the blue and the green rows here, the should use and may use. The can use, that's okay. We can certainly utilize that for treatment. And then the knowledge gaps, it's really, an adjunct, something that I guess feasibly could be part of a larger treatment plan, but certainly should not be the focus of a treatment plan for our patients with acute low back pain. So just looking through here, there's things like dry needling, traction, movement system impairments, cognitive functional therapy, those types of things. Again, just adjuncts, nothing wrong. It doesn't mean they don't work. It means we don't have evidence for it yet. It could be that down the road, they do more research and it turns out that it does or it doesn't. But until that data is there, we really shouldn't be focusing our treatment time on this stuff. So keep it up to the should use and may use. Again, you'll notice thrust and non-thrust mobilization under the should use category for manual and other directed therapies. We're going to go over the thrust stuff in person. We'll discuss some of the non-thrust joint mobilization stuff here in the online portion of the course as well. Here we have the same chart, but for chronic low back pain. You'll see that there are more options here for chronic low back pain. There's been a little bit more research on this because it is such a large problem, such a high percentage of people that have back pain go on to have recurrences and have some chronic issues or low level of disability there. So there's a great deal of research on the topic. You'll see in should use, we have a lot more options, exercise, aerobic exercise, aquatic exercise. Again, thrust or non-thrust joint mobilization is included under manual. Patient education, we have pain neuroscience education, just not as a standalone treatment. And again, recommendations to stay active, yoga, stretching, Pilates, and strength training, just as some options there. You'll see even under exercise, under should use, there are some studies that focused on specific populations. So movement control for people with movement control impairments, for older adults, just general exercise training. So there are some specific focuses on some of these. Under the may use category, there are some further options here, whether it's MDT, prognostic risk stratification. Again, education, not as a standalone treatment. Trunk activation, movement control. And then some of the can use, general exercise for post-op patients, dry needling falls under this category. Cognitive functional therapy falls under this category as well. There are still some knowledge gaps in this area. Basically, we don't have a lot as far as comparisons of different approaches. So we have all these options like aquatic, aerobic, general exercise training under the should use category, but we don't necessarily know which one is better or which one is better for whom. We also don't know dosing. In other words, how much exercise, how long, what intensity, how frequently, all of those types of variables we are unsure of still based on the research. There's not a lot of comparison of manual versus active treatments. And we don't really know what the value of manual therapy is in the multimodal approaches. We do know certain manual therapy interventions can help, but do they add to the treatment effect when combined with exercise, and if so, how much? And then again, there's not a lot as far as direct comparisons of different risk stratification systems. So we'll talk a little bit about the lumbar exam now. Like we discussed earlier, we're not really looking for a pathoanatomic cause of low back pain, like we talked about in the section about the Lancet Low Back series. There aren't really clinical tests that help identify most causes of low back pain. And again, the pathoanatomic cause is unlikely to guide our treatment. What we're really looking for here are, what bothers it, what doesn't, what feels good, what doesn't seem to help, what is indifferent, and make sure, one, that it truly is a mechanical cause of low back pain, And two, use that information to help guide the decision making of what types of exercises are we going to recommend, what type of manual therapy, education, all that type of stuff. So really, we're just going to look at lumbar active range of motion, potentially segmental mobility assessment, see which segments hurt, which ones don't. Any centralization with movement testing. Prone instability testing can be a really helpful test because it can help guide treatment decisions in a very direct way, meaning we may do stabilization exercises if we find a positive prone instability test. Aberrant movement, Gower sign, catch, a reversal, lumbopelvic rhythm, straight leg raise and slump testing just to test for any radicular symptoms or nerve-related symptoms. Trunk muscle power and endurance. Again, if we're finding a lot of weakness there, this might be something that we want to dive into to try to strengthen and help, which will help manage their symptoms. And then passively, hip internal, external rotation, flexion, and extension. There's been some research indicating that hip mobility can be an influencer of low back pain. In other words, if we have a lack of hip mobility, the hips are really tight, this can be a contributor to low back pain. The other part of that is testing for internal rotation is going to fit with the clinical prediction rule, which we'll discuss a little bit more for using thrust manipulation in the lumbar spine. Like we discussed earlier, there are certain specific causes of low back pain that require very specific treatments that we should be evaluating for and checking for. And these generally fall under the red flag categories. So some of them are going to be age-related, age under 18 or over 50. Younger patients without a history of trauma presenting with acute low back pain, we got to make sure we're checking for congenital defects, spondylolysis, or vertebral fracture. As well as the typical like night pain and weight loss. Again, those are their own separate categories for red flags as well. And then patients over the age of 50, we're looking at any type of tumor, infection, or intra-abdominal process. AAA, pancreatitis, kidney issues, those types of things. And we need to bear in mind if the patient is over 50 and has or is at risk for osteoporosis, we need to bear in mind that we need to kind of keep our eye out for signs of a vertebral compression fracture, which can occur without an awful lot of trauma, especially if the patient is osteoporotic. Anticoagulant use, fever, obviously looking for infection, malignancy. Any genitourinary issues, we're looking for cauda equina syndrome. I think most of us probably asked that question. Any bowel or bladder changes. Immunocompromised patients, keeping on the lookout for fracture and infection. IV drug use can lead to infection. Recent surgery or injection, those can increase the patient's risk for infection as well as hematoma. And then again, trauma, fracture, hematoma. So those are generally going to be the things that we're looking for as part of our subjective exam. And then we will look at things that we look for in our objective exam, the physical exam, reduced sphincter stone, hyperreflexia, hyporeflexia. So most of us, we should be testing reflexes, especially if we have a suspicion for some type of cord compression, lower extremity muscle weakness, myotomal weakness. So again, looking for cord compression, cauda equina syndrome, and then saddle anesthesia. That should be also things that we're looking for in the physical exam. In addition to that, I would add the sensory exam, again, just to check for any type of nerve compression, spinal cord compression. This was an interesting study that examined what do patients with back pain want. It was a systematic review of 41 studies that examined patients with low back pain and what do they want, what do they expect out of their healthcare provider. The first subcategory, we'll call it, was information. They wanted information on a diagnosis, prognosis, treatment options, and self-management strategies. And then how it was delivered. They want it delivered in a personalized, understandable way, in a suitable tone. So a couple things here that jump out to me, and I think this is where a lot of the challenge in treating patients with low back pain comes from, is that first piece of information that they would like is a diagnosis. And as we discussed, when patient diagnosis is not particular, I should say a pathoanatomic diagnosis is not particularly necessary and in fact is not helpful in treating this population. So how do we square the patient's desire for a diagnosis with the fact that offering them a diagnosis in the form that they would expect is probably going to decrease our odds for success? I think this is where we get the opportunity to have a discussion with the patient about what is going on and what is not going on here. Being able to sit down and have a long discussion that, yeah, you have some of these, most of the time a patient that's come to us has had an x-ray already. And yeah, you have some of these changes going on in your back related to, and whether it's degenerative disc disease or stenosis or whatever, because the vast majority of patients are going to have some degree of that. That in and of itself is not sufficient to explain why you're in pain. And going on to explain why their back may begin to bother them, as far as some of the other things that you may have discussed with them or found on your eval. So, okay, your activity level has increased recently. You've been, standing more often, cooking for the holidays. You started a new exercise program that you kind of started all at once, and you're going 5 days a week. Their activity level changed. And that may be a contributor, and some additional stress related to the holidays can be a contributor. We can have a little bit of a longer form discussion with our patients here to satisfy that diagnosis expectation. The reason that it's important to satisfy that expectation is the same study found that when patients' expectations were met, the likelihood for a good outcome increased. So we do want to try to meet these expectations, but we don't want to disseminate false information to our patients. So the diagnosis one is a really challenging one, I think. And being able to have a longer form discussion about what is going on, what probably caused it, why does my back hurt, and being honest with the patient and kind of going into some detail about why these types of things happen, as opposed to, well, your back hurts because you have, some degenerative disc disease, it's bone on bone, whatever description might come easiest. We've discussed prognosis quite a bit. Treatment options, again, this is where it can be challenging. There's not a cure. Patients are sometimes looking for okay, well, what pill, what shot, what exercise, what thing are you going to do to fix me? And we need to have a discussion here about actually being active, remaining active, exercise. There may be some manual stuff that we can do to help with this. There may be some varying techniques to use, but in general, there's not a cure. This is going to take time. We're going to kind of start today and build on it going forward. And so having that discussion with the patient is helpful as well. And again, a lot of patients want self-management strategies, so we should be really leaning on the home exercise program here. And again, we want to deliver it in a way that the patient's going to understand, and not in a way that's frustrated or anything like that. That is one of the big things that pops up in this study, is that patients often feel misunderstood, stigmatized, and trapped within the medical system. People with low back pain, centered around the desire for diagnosis, simple explanations like age-related changes and wear and tear were unacceptable. So again, if the patient can't understand it, they're going to wind up frustrated. So we need to make sure, and we can kind of use the teach back method, have them spit back what you had explained to them to make sure they understand the information that you've given them. On the previous slide, we discussed that one of the things that the patients want are treatment strategies and self-treatment options. So here's a non-exhaustive list of some of the things that we can offer. Exercise, and there's a lot of different variety of exercise that we can offer our patients. Coordination, stabilization, strengthening, and directional preference-based exercise or McKenzie-based exercise. Education is going to be a huge part of our treatment plan, kind of explaining what back pain is, what it isn't. And then manual therapy. Thrust and non-thrust both have a role to play here. The thrust we will discuss at the in-person component of this course, and non-thrust we'll talk about a little bit here going forward. We talked in an earlier slide about the importance of adhering to what the research kind of supports and guideline-based care. So it's important to know kind of what we should not be spending our time on. And this slide just discusses some of those things. So traction, not a lot of support for lumbar traction. Again, we've talked ad nauseum about biomechanical explanations for pain should be avoided. Single or definitive cause for initial episodes of low back pain should also be avoided. Like I said, it's complicated. We need to try to convey that to patients in a way that they're going to understand. But it's not because you sat wrong or bent wrong or lifted wrong. Our spine's more resilient than that. It can tolerate variability in movement. posture as a cause of low back pain, or the idea that there is a such thing as an ideal posture. There's been a ton of research in recent years on the topic. I know it's something that we were all kind of taught in school and has sort of become a cultural wisdom that posture is the way to avoid having back pain, and it's just not well supported by the research. First of all, there's no such thing as ideal posture. They've done some studies where they've asked therapists or MDs or even the public to identify good and bad postures, and there's very little agreement there. So it's certainly not one of those things that we can point to as a cause for back pain, and it's certainly not something that we can try to change to fix low back pain. It just doesn't show up as a cause when it's studied. That doesn't mean altering, moving, changing positions doesn't work. It just means that there's no such thing as good and bad posture. And again, our body's more resilient than that. We need to avoid that as an explanation. Electrotherapies are not well supported. Belts, corsets, not well supported. And orthotics are also not well supported. Unfortunately, these can create challenges. We've all had patients that come in and they swear they got tens for their previous bout of low back pain and it worked. When the reality is it was probably just natural history, like we talked about, that first month, and within the first 3, certainly most people improve a great deal. So you could stick them on tens and do nothing else, and they'll probably improve a little bit. And the patient's going to chalk that up to the intervention they received as opposed to just time passing. Those can be challenging conversations to have with patients, but the better job we do communicating kind of with each other and minimizing how often we're using these types of treatments, the less often we have to have those challenging conversations with patients to help get rid of low value interventions. So what types of exercise work for low back pain? The good news is there are a ton of options. Trunk coordination strengthening and endurance exercises, directional preference exercises, nerve mobilization exercises, aerobic and resistance exercise, Pilates, yoga, posterior chain exercise, all have papers that support their use for either acute or chronic, and in some cases, in a lot of cases, both types of low back pain. So the next slide, we're going to talk a little bit about how do we make decisions about which ones to use. This is where we have the opportunity to use our skill in clinical decision making to individualize our exercise prescription for our patients, because there are a lot of options and there are not a lot of specifics in the literature just yet as far as how to dose it, which exercises are better than others. That research just doesn't exist, like I talked about in those charts from the clinical practice guideline. So we can individualize a lot here. And the way we should do that is by looking at what's going to work for our patient, and not just how do things look on the eval and what's going to work in the sense of what's going to make them feel better, but what are they going to be able to do? Because remember, we're trying to guide them towards self-management strategies here. So what's going to allow them to be the most consistent? What type of intensity do they like? What type of supervision do they have? Do they work with a trainer? Can we get a little bit more complicated because they have somebody with some level of knowledge that's going to be with them? What mode? Do they have a treadmill at home and they really like walking on the treadmill, or they have a great neighborhood that's walkable and they want to do a bunch of walking? Great, let's focus on the aerobic exercise part. Versus somebody who has a weight room built in their garage and they love lifting weights. All right, great, let's focus on that then. What are we trying to target? Do they have weak hip muscles on exam, or are they really tight or stiff through the hips? Their lumbar spine is stiff or weak or lacks endurance, or whatever the case might be. That's where we should focus our attention. What are their goals? Obviously, every patient wants to get out of pain, but beyond that, do they want to be able to hike? Do they want to be able to pick up their grandkids? Do they want to be able to walk through the store without their back bothering them? Our exercise should reflect that and should be specific towards those goals. Again, what are their impairments? What's weak, what's tight, what's strong? Where do we need to focus our attention? Tissue irritability is going to guide this quite a bit. Obviously, things a little bit more irritable. We're going to have to back off on the frequency maybe and the intensity and all that kind of stuff. Things start to calm down, settle down. We can get a little bit more aggressive, start using some heavier loads, increase the intensity, frequency, total volume, whatever the case might be. And then movement competency. We've all worked with patients that just don't move great, and we've got to pick simpler exercises for them. And then other people that have a background as, they were athletes and they've lifted weights, they've exercised in some way, shape, or form for their entire lives. you go to show them something and they pick it up instantly, you can afford to get a little bit more complicated with those patients. So, we need to tailor that to, what is the patient going to be capable of doing on their own safely and confidently, more importantly, because they need to feel like they can do this on their own. If they're feeling intimidated by or unsure of the exercise, it's either not going to happen or it's probably not going to help because they're going to be kind of half in it. So we need to make sure we tailor it to their skill set as well. So what role does physical activity play? Basically, it has an inverse relationship to incidence of low back pain. In other words, those that are more active during their leisure time tend to have lower incidences of low back pain. It's not a linear relationship or a dose-response relationship, but again, higher levels of activity generally are going to confer lower levels of risk for low back pain. Where we lose the dose-response and linear relationship there is at the extremes. People with exceedingly high levels of physical activity, think your ultramarathoners, tend to not fit into this category and kind of break that relationship a little bit. These are not generally the patients that we're seeing. So recommending to increase their physical activity is most of the time going to be sound advice. Again, we talked about earlier that leisure time physical activity seems to be the most important. Occupational physical activity does not appear to confer the same benefits. The reason this is important is we've all had the patients, I know I have, who come in and, you're like, well, we need to get you exercising and, here's some stuff to do to strengthen this or strengthen that. And they're like, well, I've worked a physical job my whole life. I don't need to exercise. And again, it turns out for whatever reason, it is different. There's not a lot of research or definitive answers as far as why that's the case, but it is. So encouraging those individuals that, you're plenty strong, your job is physical, all that, but I think getting some physical activity outside of work would be helpful for you. And, we want to tie all of this into our exercise prescription decisions. Because our goal should be when our patients leave us, they have some new type of regular physical activity. Here's the thing. There's a lot of opportunity, a lot of options. Like we said, we don't have a lot of comparative literature on this stuff, so there's a lot of options as far as exercise. Find the one that your patient likes. I tell patients all the time, I almost don't even care what it is. I just want you participating in some type of physical activity regularly. So let's pick the one that you enjoy because it doesn't appear to matter all that much. And that same sort of logic will apply to the patients with high levels of occupational physical activity. That, I don't want this to feel like a chore for you. I know you're active at work, and I know the last thing you want to do is think about maybe lifting weights when you get home. But what if we just went for a walk? What if we rode a bike? What if we went for a hike? Find something that they enjoy. Maybe it's yoga, maybe it's Pilates. It doesn't matter. It needs to be enjoyable for the patient. Otherwise, they're unlikely to stick to it, particularly with those who feel like they're already working really hard physically at work. They're not going to want to go home and continue to be physically active and place that extra demand on their body. And again, it should be tied into our exercise prescription decisions. If a patient's like, oh, I really, I started to get into Pilates or yoga or used to do it and really enjoyed it, our exercise prescription should kind of look like that to help ease them into that and so that they can just kind of take off running when they're done with us. So we want to make sure we're considering all of that when we're making decisions about what exercises to do in clinic and what to prescribe for home programs. So the next question is, what should our patient education look like? The long and short of it is right here. So we want to recommend to patients that they remain active. If they're already participating in some type of regular physical activity, we want to encourage them to continue to do that. If they're not able to do it fully because of pain or some other limitation, we want to work with them to find a way to modify only as much as we need to allow them to continue. Again, maintaining as high a level of physical activity as possible within their tolerance is going to be key. We definitely want to avoid bed rest. That was a recommendation for a long time. I still get patients once in a while. They're like, oh, I had this, 20 years ago, and doctor told me to, just rest and lay back and not do anything. And eventually it got better. We want to avoid that. We know that now that doesn't work. We want to educate patients on the positive natural history of low back pain. Generally, again, within 3 months, people have experienced some pretty significant relief. We want to reassure them. No serious underlying pathology is likely in the case of low back pain. In most cases, an underlying pathology can't even be identified. It's what we call nonspecific low back pain. In cases of chronic low back pain, pain neuroscience education can be helpful, discussing what pain is and is not, particularly in cases of chronic pain. And then again, at the risk of sounding repetitive here, we want to avoid purely biomechanical explanations. So your back hurts because your posture is this way, or because of the discs, the jelly came out of the donut, or your facet joints, the joints in your spine are worn out, and you've got degenerative disc disease. These are all explanations that we want to avoid for our patients because they lead to unhelpful beliefs about low back pain and, again, worse outcomes over the long term. Manual therapy in low back pain should be used in combination with active treatment. It is superior to active treatment alone in some subgroups of patients, and it can be both thrust and non-thrust. The thrust we're going to focus on in the in-person part of the course. We'll talk a little bit more about non-thrust in the next slide. But the important thing, and one of the highlights of the research on thrust manipulation, is there is a clinical prediction rule for when it is useful. We'll go over this again. We'll repeat it when we're in person. But the clinical prediction rules in a study came out of a study by Flynn et al. Symptoms less than 16 days, no symptoms distal to the knee, lumbar hypomobility, at least one hip with greater than 35 degrees of internal rotation, and a fear avoidance belief questionnaire score of less than 19. You'll see that I starred the first two, the symptoms less than 16 days and no symptoms distal to the knee. And this is because there was a study that found that actually if the patient checks those two boxes, they are likely to benefit from thrust manipulation. The other three only increase the likelihood marginally, so it's not a huge difference, and basically the focus should be on those first two, that the patient has experienced symptoms less than 16 days and they have no symptoms distal to the knee. Next, we're going to talk a little bit about non-thrust manual therapy. So what's the utility of non-thrust manual therapy? Similar to thrust manual therapy, it should be used in conjunction with active treatment. Again, some studies indicate that manual therapy plus exercise is better than exercise alone. So again, including it with the active component is useful. Can target both the hip and the lumbar spine, like I suggested before. Sometimes stiffness, tightness, lack of range of motion throughout the hips can contribute to pain around the low back. Some studies do indicate it can deliver the same results as thrust manipulation. Others indicate that thrust carries with it some benefits beyond just non-thrust manual therapy. There is better evidence for joint mobilization than for soft tissue techniques. So soft tissue mobilization, while it may have a role, it does not seem to be as successful or as beneficial as the joint mobilizations. And it can be useful to substitute non-thrust manual therapy if you're unable to perform thrust manual therapy. And it might be because it's contraindicated in a given patient. It might be due to physical therapist's lack of comfort with performing it on a certain patient. It could be a body habitus issue. Certain patients are just more difficult to perform thrust manipulation on. So all those are reasonable thought processes to substitute non-thrust manual therapy in place of thrust. Again, there are some studies that indicate there is some unique benefit to the thrust component, and so where possible, and given that following this course you'll have the skill set to do so, we should be using that where we can. We will see you all on 12/6. We will discuss more about thrust-based manual therapy for the lumbar spine. There will be some didactic. We'll have a little bit of PowerPoint, but most of it's going to be lab time. So look forward to seeing you in person. Take care.